Hello, and welcome to episode 80 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. We're here today with Peggy OKane, President, CEO, and founder for NCQA, the National Committee for Quality Assurance. Peggy, thank you for joining us today.
Very happy to be here, Jordan.
Excellent. So the first question I'd like to ask you is, what are you currently doing, or what have you ever done to advance the public interest, and why?
We're all about advancing the public interest. When I started with NCQA, actually I had been working on the issue of quality health care for a long time before NCQA was launched. I actually started my career in healthcare as a respiratory therapist, and that gave me an opportunity to observe what was going on in hospitals because I worked in hospitals. And while a lot of great people work in healthcare, the way it's organized and put together, the patient falls between the cracks.
Right.
And so as a respiratory therapist, you're working with a lot of different patients across boundaries of medical services and so forth. You really see it. And so I did it for 5 years in a number of different places, some really good, one very, very good hospital, the University of Virginia, and some not so good, who I won't mention.
Right.
But in all cases, I saw that there were bad things that happened because the work wasn't organized as well as it could have been, or standardized in the right way.
So you're sitting as a respiratory therapist, you're working with patients every day, it's hectic, you're frustrated,
Yes.
and you see things, people falling through the cracks, and you think to yourself, gosh, something ought to be done,
Yes.
but what can I do? I'm only Peggy OKane, respiratory therapist, one employee of thousands, tens of thousands in this country.
Right.
What can I do to make a difference? How did you answer that question?
I said, I'm leaving respiratory therapy, going back to graduate school. And one of my bosses said I was like a Girl Scout on a rocket. And so that's been, when I started in quality, I got my master's degree from Johns Hopkins, and I learned a lot about theories of quality. And, there were a lot of research studies that were showing that quality wasn't what people thought it was. Like, doctors were shocked to find out that a lot of their patients that should have had a certain thing didn't get it. Health plans were finding this out.
Right.
And so we tried to find a way to move the quality agenda forward.
So on that topic, if I may interject, there was a lot of, there's been a shift from a conceptualization of medicine as an art, the art of medicine, to now something that's more of the science of medicine. Originally, there might have been some pushback from providers who said, "Look, you can't,
that's over.
you can't quantify quality. Quality is subjective. I think I'm giving a great quality of care." How is it that you have participated in this national conversation and shifted it from the art of medicine to the science of medicine?
Yeah. Well, I think there's still a lot of art left in medicine.
Yeah.
The science, it remains kind of uncertain in many cases. We have, we were all about, from the beginning, and still are, about evidence-based medicine. That is there proof that what you're about to do to this patient is going to make them better? And so, we have guidelines about preventive services. We built measures off that. How many women over 50 had a mammogram? How many people had a pap smear? How many children up to date on their immunizations? And so those are all preventive services. And then we got into interesting areas like common chronic illnesses like diabetes, which is a huge killer in the United States and around the world. And there were the American Diabetes Association, and even at NIH, they were working on standardizing the evidence so that it was very clear what you should be doing and what is a good control level for a person's hemoglobin A1C and so forth.
So there's population quality health measures, and were any of these being developed when you first became aware of quality measurement?
Well, they had been developed for scientific studies. So people were publishing in medical journals. Wait a minute, only 30% of this happened when it should have happened 100% of the time.
Right.
But there is a way in which our evidence is developed, which is, if you know the National Institutes of Health, they go by disease category, right?
Sure.
Or
by organ, which is the way a lot of physicians.
Exactly. But people don't come that way. And so, if you have a person with diabetes, they will often have heart disease, depression. They may have a cancer or something. So people don't come in neat packages like that. And that's where we're still kind of groping, trying to figure out, what should be done scientifically. And so art of medicine does come into it. We're never going to have 100% absolute certainty about what should happen, but we should get closer than we are today.
And so just as a patient isn't only, HIV positive or renal failure or whatever different comorbidities we spoke about, but they're a combination of things.
Right.
Peggy OKane, you are not just the CEO and founder of NCQA, but you also are a mother. You also have been a teacher. Can you talk just about how you've been driven to advance public interest? What attracts you to public service? Why is it that you feel a calling to make the world better for other people? Why not just take care of yourself?
It's a complicated question. I don't know. I think I've felt that way since I was a little girl. You mentioned that I'm a mother, and let me just go down this track. It wasn't where you were trying to lead me, maybe, but my daughter, when she was 9 years old, we found out she had a heart defect that needed to be surgically fixed.
It must have been scary.
Terrifying. And at the time, I knew enough about quality to know that some places were better than others. So I got out my yellow notepad and I went and interviewed people at the different hospitals that did this surgery.
By phone?
No, I went in person.
You went in person and interviewed?
There were only 2 hospitals in the area.
Okay.
So, but I actually did by phone talk to Boston Children's Hospital, which is very famous and where I had worked in my youth. I found out a lot of interesting things, but I couldn't get any data because nobody had a standardized way of calculating mortality in surgery and so forth, especially in child's heart surgery, which is smaller in volume than adults. So, it's interesting because in the course of the conversation, somebody thought that I had heard about some quality issues that had come up at one of the hospitals, and he started telling me all about it, and I hadn't known. Maybe it had been in the paper and I'd missed it or something. If you put on your detective hat, you can sometimes find things out, but it really was not satisfactory. And we still aren't at the point when you can have really good outcomes data for even adult bypass surgery or valve replacement and so forth.
So as a consumer,
except like in New York, you can.
So as a consumer, and especially as a mother of a sick child, it's very difficult to do comparative analysis and be a smart consumer when you're choosing where. So
that motivated me. But even when I was having my babies, I was in that generation. Our bodies, ourselves. We were taking back childbirth from the medical system because we didn't think it was a medical thing. And so I think that our cohort, I'm a baby boomer, really got involved and wanted to have, natural childbirth. And so we all took Lamaze and so forth. And that seems to be coming up again now with our daughter's generation. But in the meantime, I think the activism that women took on about childbirth seems to have faded to some extent.
So it seems like a lot of the work that you're doing is, first, you've spoken a little bit about, I feel, and I hope I'm not putting words in your mouth, women's empowerment, and you mentioned perhaps the feminist movement.
Yeah, but it really wasn't coming from that so much as from, as a person.
As a person.
Yeah, I mean, I'm a feminist.
Yeah.
But I think that the idea that, I had read many things about what happened to women in childbirth, and I had talked to people and so forth, and my mother's generation, my mother had me in Germany. I was born in Germany. But, when I was born in this country, women were knocked out and given all kinds of weird drugs that made them have nightmares and so on. So, there was a reason why this movement started to take back childbirth. And it was really primarily driven by the idea that childbirth needed to be a healthy and positive experience for mothers and babies.
And did you take that with NCQA to the next level where you're empowering patients to make informed decisions about their health care, whatever that may be?
Well, I would say that we're partially on the journey. It turns out that, a lot of people aren't thinking about their health all the time. They have a lot of other things to think about, right? Their jobs, their families, their responsibilities. And so when they're healthy, I think they might be looking at our ratings when they pick a plan. Certainly Medicare gives star ratings now to Medicare Advantage plans.
Sure.
and we collect a lot of the data for that.
For our listeners, Medicare is a public health insurance company through the federal government or product that's offered to all individuals age 65 and over, in addition to a few exceptions beneath 65. And Medicare Advantage is also referred to as Medicare Part C, which are essentially health maintenance organizations, meaning...
Not always. Well, they're health plans.
They're private.
Yeah,
they're not
private.
public.
Yeah. So we do ratings for them. We
Mm-hmm.
do collect the measures. CMS actually does the ratings. And we found that that is one of the real success stories about consumer empowerment,
Right.
because actually CMS very cleverly gives extra money to the real high-performing plans so that the plans can put the money into enhanced benefits, like hearing aids, glasses, and so on. And so people look and see, this is a 5 or 4.5 star plan, plus I get extra stuff. And so they go for the high quality.
So you're actually influencing consumers' decisions.
Yes.
So tell me more about the mission of NCQA and how it evolved. I mean, from the very beginning, when you're sitting as a nurse in a hospital, there are many different things I could say, oh, well, I got to change the money, or, oh, maybe I should run for Congress and change policy. How is it that you decide, well, not only is quality measurement, which there wasn't as much of a quality measurement enterprise when you started this in the early 90s.
There wasn't any.
Wasn't any.
Yeah.
So you decide quality measurement's the thing to do, and not only that, but an advocacy organization, a nonprofit, that's the thing to do. How does someone, and then you had kids, you had a salary, you left your job. How does someone take that leap?
I don't know. You have to be a risk taker. I mean, I think a lot of times in life, I was a little bit bored with what I was doing before. So when my children were really small, I was kind of a researcher out at George Washington University, where I learned a lot about state health policy. I worked in a state health policy group, but it just felt, kind of like I wasn't clear that anything I was doing was changing anything in a positive way, and I really kind of needed that. So, I got a job. I got a couple of jobs with the federal government. I learned some things, in the federal government about, actually I worked in the Health Services Administration, which runs community health centers and maternal and child health programs, and they were all about evaluating impact. So they had measures, rudimentary measures, and so on. So I left the government, and I went to work for the Health Plan Trade Association. It was at a time...
Is that AHIP?
It's what it was prior to AHIP. It was called Group Health Association of America.
And was that affiliated with the Group Health Provider Organization, an HMO that used to be in...
They were a member.
Okay.
Yeah, I also worked there for a while, for about a year, 11 months.
Okay.
That's another story. But anyway, so I went to work. I was still looking for the way in which I was going to change the quality of healthcare, which hadn't happened. Right? So this was I worked there. I learned a lot, but we really were about giving grants to others to do the work. And so when I went to work for GHAA, they were really, there was a movement of employers to put people into HMOs, which at the time did not have a bad brand, but they were also concerned that these were Fortune 100 companies, they were really elite companies, worried about the health of their people.
So these companies were providing health benefits to their employees.
Exactly. And so they wanted better information about who are they giving the money to provide the health care for their people. At the time, your typical Fortune 100 company would have people all over the country, so they were often contracting with 100 more than that health plans. And they were then in the business of running around trying to collect made-up measures by consultants. And so we came to them and we said, what about if we do this one time? You make them report, you make them get accredited by us, and then we'll turn the data over to you. And that's how we were born. That was our business model.
So how do you get the attention of Fortune 500, Fortune 100 CEOs when you're like, well, I've started my own little nonprofit? Did you ever have any failures? Did you ever have fear that it wouldn't succeed?
The employers were groping around looking for a way to do this more efficiently. They understood that having their little teams running around inspecting every health plan was inherently very, very inefficient, and that they were tying up the health plans with all this reporting rather than actually improving quality of care. And so we came along at a moment when it was, they were looking. We were kind of trying to figure out how we were going to work with them. And the better health plans, the ones that thought they were higher quality, because nobody really knew at the time, wanted this to happen because they wanted to prove their worth.
Yeah.
And so they often put us in touch with their customers. So, I mean, NCQA is not about me. It's about all the people that came together to make this happen.
Have you ever, I'm just kind of thinking about outside the box, and this may be out of left field, but I'm thinking, when you have a McDonald's that has so much control over the supply chain, they can change how farming practices of cows, Purdue and chickens, Walmart and T-shirts from China. Have you ever thought, well, basically the reason why NCQA initially was successful was because you were able to leverage the purchasing power of these large corporations within healthcare. Have you thought about, affecting child labor laws who are through Nike or something through a similar.
My daughter has to do that.
I mean, expanding NCQA outside of healthcare.
No.
Okay.
No.
So we're limited to. Okay.
Yeah, it's big enough.
Yeah.
I mean, we're not even in all of healthcare. For example, we don't do hospitals. We don't accredit hospitals. We don't measure.
Do you work with the Leapfrog group?
We work with them. We have a good collegial relationship and so forth. But it's healthcare is such a big enterprise, and we're about to go through a huge change in healthcare, right? And just kind of holding on to the progress that we've made in the past 25 years, I think, could be a major challenge. And
the change you referred to is the introduction of alternative payment models.
The change in the administration.
The change in administration,
yes,
I see.
Because the Affordable Care Act, and we have worked, we've had contracts with CMS and so forth. But, I think that there was a point of view of the administration for the last 8 years that was very activist. People didn't know as much about the quality agenda, but they had a huge quality agenda too. So, I mean, now we just don't know yet. We know who the secretary is. We know who's going to be the head of CMS. We haven't met either of them.
Right.
So it may turn out to be just great, but any change in administration usually means big changes, and in this case, bigger than usual.
So pivoting back to you a little bit and your story about public service, you're starting to gain some traction. I'm sure there were many different times when you weren't sure that this would actually. Were there times when you were sure that this might not succeed, or when you were doubting yourself, and how did you get through those?
Yeah, I don't know. I had good board members that said, don't worry, just keep plugging away.
Did you ever have a plan B or a backup plan?
You mean for my career?
Yeah.
No, I mean, you do the job. And when I took this job, we had a grant from Robert Wood Johnson Foundation for $300,000. And there was a one-time fundraiser from the plans to have a match. So we had a budget of $600,000 that was supposed to last 3 years.
Yeah.
So I took the job. That was a big leap of faith.
So okay, so you took a big leap of faith, and you've slowly developed this organization. Tell me a little bit about NCQA. How large is it? Why is it based in Washington D.C.? And what is it? What are you most proud of at this time, having built?
Okay, so our budget is about $65 million a year, I think, for next year. So not very big compared to...
How many employees? 320,
I think, is where we are right now. So we have a lot of surveyors out there. So when we accredit a plan, it's not all NCQA employees that go. It's typically surveyors who we contract with, who are typically doctors or nurses from practice and so forth. We also have this patient-centered medical home program, which I haven't talked about, which is primary care. In those, so we have various things that we do. What can I say?
Well, how receptive has...
Why is it in D.C., you asked me?
Why is it in D.C.?
Because I lived in D.C.
And okay, so...
because the Trade Association was here, and D.C. has been a nexus for a lot of things that have happened in health policy. There probably isn't a better place in the country that you could be if you're trying to do something national in healthcare. But we also have a California office. We have, I think, 5 people out there now. We do work out there. California's like its own country.
So Congress has been in gridlock for some time, but of course this hasn't always been the case. Did you ever consider trying to advance NCQA's agenda in state legislatures instead of in the U.S. legislature?
We actually work very closely with a lot of states.
Okay.
So we don't typically go and lobby for laws. What we do is present to policymakers or people who are trying to run, a program in healthcare. We have this accreditation program, which is of interest in the states to Medicaid.
Right.
People that run Medicaid, which you want to say what Medicaid is?
Oh, right. So Medicaid is also from Lyndon Baines Johnson's 1965 Social Security Act, which basically provides health insurance coverage to the indigent,
Poor people.
And it's run in partnership with the states, which is a compromise, so more federated, as opposed to Medicare, which is run through the federal government. Medicaid is in partnerships with the states, and therefore the program varies greatly across all 50 states.
Right. So that's a retail job for us. We have to go meet with the states. We go to meetings, Medicaid directors meetings. We give speeches. Sometimes that opens doors. But I think we have 38 states now where somebody says either you have to be accredited by NCQA if you're going to do business here, or if you get accredited by NCQA, we will lighten up our piece of the regulatory puzzle. So it's called deemed status.
Yeah.
NCQA did this, that's good enough for us, and then the plan goes forward.
So 2 more questions. When you look at what you were trying to accomplish to do, there was the vision that you had, which was to improve, the ability...
Quality of healthcare.
Quality of healthcare. And then there was also the promise, the value proposition you initially made to the Fortune 100 companies, which was, we're going to make this easier for you across the country to just choose your menu and see which company you want to contract with.
Right.
So how successful have you been with those 2 missions, and to what extent, how have the different stakeholders reacted? Have they been grateful, and have they received you with open arms?
Well, the plans that do well naturally are happier with us than the plans that don't do well.
Right.
So that's normal. We not only accredit, we give a rating to plans, star ratings ourselves to commercial plans. The employers, I think, a big change that has happened since we started working with the employers is they're self-insured now, so they only have like one health plan, and the health plan is not really at risk for the dollars. It's the company that keeps the risk, and so that's changed the dynamic. They no longer have their employees choosing from a menu of options. They just have one option, which is their plan. I think what's gotten better since then is our relationship with CMS, our relationships with the states. We've changed the quality of care. And
are Americans healthier?
No. I can't say that. I can say that healthcare is better.
Healthcare is better.
In some ways. But and I have to give a big caveat, because I'm sure there's somebody listening who's saying, wait a minute, I'm paying $5,000 out of pocket before my first dollar of coverage kicks in. And that's not what I'm talking about. That's something that I think is kind of problematic.
That you're referring to health insurance coverage as opposed to health.
High deductibles. Yeah.
Right.
Yeah. But as we look at the measures over time, we've had massive improvements. Like, for example, many more Americans who have hypertension are now in control, which means many fewer are having kidney transplants, blindness, heart disease, etc.
So you have made people healthier, and you potentially have saved lives.
What I need to say, and I'm not that modest, but there are a lot of things that drive your health. Your behaviors drive your health in a way that, healthcare is often trying to come in and play catch up.
Right.
Once you've messed up your health, right? By being obese, by smoking, or by being stressed out and working all the time. These things are very, very important. Or if you're poor, that has a huge impact on your health. So we are working on the healthcare system, making that better. There's another whole big agenda about public health and making, soda taxes, for example, and smoking taxes and so on.
So we're nearing the end of the podcast, and I'd like to ask a final question, which is, as you reflect upon your lifetime in public service, whether it was in education or primarily in healthcare. There's some policy implications to your work. You've done a lot. You've left an impact. You're, at least, in the very least, you have 300 and some employees who are able to take care of their families and have their lives. You've done a lot. I'd like you to reflect on your legacy. Why have you done this? What have been your primary motivations, and why is the world better because you've been here? What are you leaving behind?
Well, I have been committed to public service my whole life, and I did work in the government for a while, and I just found that this was there was more of an open pathway. There were less political reins on us at the time, so I think we were able to move an agenda that probably couldn't have started out in the government. And it's one of the very interesting things about being an accreditor. You can kind of hold a quality agenda and adjust it to the different political forces that are driving in the country. I think, this sounds kind of schmaltzy, I guess, but I think when I worked in hospitals, seeing patients being sick and suffering, and especially when something went wrong, motivated me a lot. And so the idea, there was just this kind of sense of outrage that I think sometimes can be very constructive if you can put it to a good use. So it just was like, no, it shouldn't be like this. It should be better. And it is better because of what I've done and the people that I work with.
So that's Peggy OKane, CEO, founder, and president of NCQA, who speaks about a lifetime in public service as having begun with individual patient lives, a frustration in seeing the way things were, acknowledging and having a vision for how things could be better, and then applying oneself with diligence and perseverance across great obstacles and seeking things that may not have appeared at first blush to have been the most realistic, but to have succeeded beyond any possible expectations in really changing the national conversation about quality measurement and improving healthcare outcomes for Americans. So, Peggy, thank you so much for joining us.
I have one more thing. You can
Please.
This, right? I think if young people are listening to this in the course of trying to figure out their career, I think when you say I had a vision and I went and realized the vision, you don't get the whole vision at one time. You get an opening and you try to do something, and then things unfold in front of you when you're doing something new in particular. And I think it's a time when there are so many opportunities to rethink the way we do things. So I think that if you're sitting around waiting for the full picture to emerge in your vision, you can spend your whole life that way.
So take action now and see where it leads.
Yes.
That's Peggy OKane, and this has been episode 80 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. Thanks for joining us, and we will talk to you next time.